Hello, my name is Michael Huang. I am a student pharmacist at Mercer University, College of Pharmacy, and this is my presentation on a retrospective study over the analysis of copper deficiency in hospitalized patients with liver disease. To this date, we have nothing to disclose. Here is a copy of my poster. Copper is an essential trace element that is vital to the health of all living things. It is not talked as much as the other trace elements, but still plays a critical role in maintaining function of organs and metabolic processes such as the nervous system, connective tissue formation, iron metabolism, pigment formation, immune function, and many more. In humans, copper is primarily absorbed in the stomach and proximal duodenum. One of the potential causes of copper deficiency is liver disease, which is a severe deterioration of liver function that can be caused by a disorder or substance such as viral hepatitis, cirrhosis, and liver damage from alcohol or drugs like acetaminophen. Liver disease is diagnosed based on symptoms such as jaundice, ascites, hepatic encephalopathy, and fatigue. Liver function tests are the main labs that use to help diagnose liver disease, and these include ALT, AST, and ALP. Since copper is easily distributed across the human body and requires a low daily amount, it is quite rare to see copper deficiency among patients and even more so in patients with liver disease. The purpose of the study is to estimate the incidence of copper deficiency in hospitalized adults with liver disease. As stated in the beginning, this is a retrospective study done at Emory University Hospital, which consisted of a chart review of patients who had at least one low serum copper level during the period of January 1st, 2004 through June 30th, 2016. At our site, we considered a patient to be copper deficient if their serum copper level is less than 70 microgram per deciliter for males and less than 80 microgram per deciliter for females. In order to be included in our study, patients had to be at least 18 years of age or older and have had a past medical history of liver disease. Throughout the data collection, patient demographics, other past medical history, past surgical history, and nutrition status prior to admission were also included. A total of 1,020 patients documented with at least one low copper level during the 12-year study period. To this date, 120 patients were screened for liver disease, of which 27 patients were included in this preliminary data analysis. Patient demographics have been summarized in the table. The average age among patients was 53. The study had more males than females with 15. The study was majority white at 19. The average BMI among patients was 28.3. The average low copper level was 51.3, and at least 7 patients had more than one low copper level. All patients included in the study had some type of liver disease, where the most common ones were end-stage liver disease, cirrhosis, and hepatitis C. Throughout the study, data collection was also done on other comorbidities that could factor the outcome of copper deficiency. The most common ones found were patients who had history of renal failure with dialysis and a past paracentesis procedure. 3 patients had a surgical history with each having either gastric bypass, gastrectomy, or TABSO, which is total abdominal hysterectomy and bilateral salpingo-oophorectomy. 6 patients were also documented to have been on parenteral or enteral nutrition prior to admission. Common symptoms presented among patients were hypotension, tachycardia, and fatigue or weakness prior to admission. Based on our preliminary data, copper deficiency may be presented in patients with liver disease with a low outcome. However, there are still over 900 patients that still need to be screened for liver disease and be included in the study. Only then can we draw a definite conclusion on whether liver disease has an impact on copper deficiency outcome. Furthermore, other comorbidities could have been a factor in the outcome of the copper deficiency. The limitations for this study was being a retrospective chart review. A lot of information was not available in patient charts, especially those hospitalized prior to 2010. There was also insufficient time to collect the remaining data as this is an ongoing study. Here listed are the references used in the study. Thank you for your time and have a good day.